Welcome, everyone. Thank you for joining us. My name is Ashley Brown, and I am on the PKD Foundation's Board of Directors. Polycystic kidney disease is a disease that impacts generations in the same family. Many wonder why can symptoms look so different between family members? Here to answer all of your questions about PKD and genetics is Dr. Bernice Gittimer. Dr. Gittimer is a research professor of medicine in the Division of Renal Diseases and Hypertension at the University of Colorado School of Medicine. Her research focuses on ADPKD, in particular, genetic and other factors that affect the severity and progression of disease. Dr. Gittimer has published dozens of research articles, and among other high-profile positions, she serves on the PKD Foundation Scientific Advisory Council. Dr. Gittimer, it's my pleasure to turn the presentation over to you.
Thank you, Ashley, for that very kind introduction, and thank you to the PKD Foundation for the opportunity to present this talk today. I'm going to talk to you about genetics and how your genes affect your family tree. Next, please. I have no disclosures to make. Next, please. And this talk is being presented for educational purposes only, and any of the content that I present during the talk does not imply endorsement by the PKD Foundation. Next, please. So in outline, I will talk a little bit about the basics, some terms that we use in genetics. I'll talk about variability in ARPKD, variability in ADPKD, and some prediction programs that predict progression of disease. I'll also talk about unusual disease and cases where there is no family history of PKD. And I'll close by talking a little bit about pre-symptomatic diagnosis or testing, yes or no. Next, please. So our genes determine our genetic makeup. And when they're mutated, they also determine who will develop a genetic disease. Next, please. So to briefly describe this, I will talk about our chromosomes. Next, please. We have 22 pairs of what are called autosomes and one pair of sex chromosomes. So in the case of a female, they're XX. In the case of a male, it's 1X and 1Y. So because we have two copies of each of our chromosomes, that means that we also carry two copies of each gene. Next, please. So the chromosomes are indicated here by the blue vertical bars, and if you take a look to the right, you will see some red bars covering the blue. This is meant to represent a mutation. So first of all, let me talk about ADPKD. So in ADPKD, it's a dominant disorder. This means that only one copy of a mutated gene is necessary to cause disease. So shown in this diagram in the middle panel, here we show the red bar in the father. So the father can either pass that copy of the chromosome with the mutated gene to one of his children, in which case they will be affected by disease, or he can pass the other chromosome without the mutation, in which case the children or the child resulting from this will not be affected. So one copy of the mutated gene is necessary in ADPKD. However, the situation is different in ARPKD. In ARPKD, both of the parents must carry one copy of the gene mutation. However, inheritance of both of these mutated genes is necessary for disease to develop. So in the carrier status, the parents are usually totally symptom-free. And in this case, the affected parents can either pass their copy of the chromosome without the mutation, and a child that inherits the two copies, one from the father, one from the mother with no mutation, is unaffected. However, they can also pass on their copy of the mutated gene in one case, and the other parent can pass on the non-mutated gene, in which case that'll result in a carrier status. So about a half 50-50 chance of a child being a carrier, and a 1 in 4 chance of the child inheriting both copies of the mutated gene, in which case they will develop ARPKD. Next, please. So now some basic definitions of mutations and types of mutations. Our DNA codes for messenger RNA, which, as it implies, is a message to make a protein. And when that DNA is mutated, there are two types of mutations that can occur. One is a truncating mutation, which results from a change that causes a stop signal to be included in this messenger RNA, in which case either no protein can be made or possibly a shortened version of the protein. And that shortened version of the protein can be broken down very quickly, shown by that little Pac-Man character. Another type of mutation is a missense mutation, and this is where it causes a change in an amino acid in the protein. So in this case, the whole protein can be made, but the shape of the protein may be affected. Also, depending on the region of the protein where that mutation or the swapped amino acid occurs, can affect a crucial function of the polycystin proteins or the fibrocystin protein, resulting in it being unable to carry out its normal function. So sometimes truncating mutations are also called null mutations. Next slide, please. There's a different type of mutation that's sometimes called a hypomorphic allele. This is a mutation that causes only a minor or partial loss of gene function, and the effects of these hypomorphic alleles are usually very mild. And this is something that we've learned about within the last decade. Next slide, please. So let's address, first of all, autosomal recessive polycystic kidney disease. This results from a mutation or two mutations in the PKHD1 gene. This codes for the fibrocystin protein, which is a very large protein with somewhat over 4,000 amino acids. The disorder is rare, about 1 in 20,000, and this unfortunately has made it difficult to do the kind of studies that have been done in the dominant form of PKD, because there are fewer affected patients. However, it's noteworthy that over 270 different mutations have already been described in the PKHD1 gene. And next slide, please. So an affected child may carry two different mutations. It doesn't have to be the same gene mutation. They have to occur within the same gene, but they can be totally different mutations. So it is possible for a child to inherit two truncating mutations, one from each parent who were carriers, or they could inherit two missense mutations. There's a recent large study where they looked at over 300 affected individuals with ARPKD. They excluded adults who were diagnosed with ARPKD, and they also excluded neonates. So they're only looking really at children with ARPKD. And they showed that indeed two truncating mutations, as you would expect, this is two stop codons, so you're kind of losing most of the functional protein, was associated with more severe disease. Also, they showed that the region of the protein that was affected by this mutation could also have some significant effects. And you can see here on the right of the protein, the mutations affecting that region were associated with more severe kidney or liver disease. whereas towards the left of the slide, you will see that mutations that affect that region of the gene were somewhat milder outcomes. Next slide, please. So to summarize this, you can see by the orange arrow at the bottom that two truncating mutations are the most severe, are associated with the more severe form of ARPKD, which typically has very early onset, sometimes even before birth. Very largely in large kidneys are detected in the children. Two missense mutations can be a milder form of disease. However, it's important to point out that, again, the region of the gene that the region of the protein affected by those mutations can also have profound outcomes. So if it's a critical region of the protein, two missense mutations could also affect disease quite severely. We also now know that there are some cases where ARPKD has been diagnosed in adults. Sometimes this can be mistaken for ADPKD, and this adult form is more typically associated with two missense mutations rather than a truncating or two truncating mutations. Next, please. So now let's talk about the dominant form of polycystic kidney disease. Shown here is a family, and typically you have an affected parent, and here you can see two affected children, and there is a mistake here. The actual child of the grandparents' generation should be affected, the one on the left. So ADPKD results from mutation in mostly two genes. PKD1 is responsible for about 70 to 80% of all cases. PKD2 is about 15 to 20% of cases. However, it should be pointed out that somewhere between 7 and 11% of cases of ADPKD, no mutation has been detected in either the PKD1 or the PKD2 genes. We'll talk a little bit about this in a minute or two. There are over 1,000 different mutations that have been detected in the PKD1 gene. So many mutations are private, occurring in only one family. And this can cause difficulties with diagnosis, because if it's a brand new mutation, it's kind of more difficult to say that it is definitely going to cause malfunction or disease associated with it. So prediction programs can be used to predict the effect of the mutation, but the gold standard is really expression of that particular gene mutation in an animal model to prove that it is in fact disease-causing. The polycystin 1 protein is a large protein, again over 4,000 amino acids, whereas the PKD2 protein, polycystin 2, is a shorter, smaller protein with around 900 amino acids. Next, please. So we talked about the 7 to 11% of cases of ADPKD. 7 to 11%, there's no mutation detected in the PKD1 or PKD2 genes. And if you look within this bright blue box, you can see towards the bottom there's a list of different genes. And these are genes that have been associated with a presentation resembling ADPKD. So why do all of these different genes cause ADPKD? Well, the polycystin proteins get modified on their journey through the cell to the correct location where they are functional. They can have sugar residues added to the surface of the protein. These may guide folding of the protein or movement of the protein again to the correct location where it's needed for its function. So interestingly, this list of genes have been shown to affect the processing of the mature protein. And the end result is less protein actually reaching the functional site. Here it's shown at the base of the primary cilium. Next slide, please. Next slide, please. So there's also a hypothesis that this was developed to try and explain the fact that not every tubular epithelial cell in the kidney will go ahead and develop a cyst. And this is called the second hit hypothesis. So one mutation is inherited on the chromosome. Then what is called a somatic mutation affects or causes a second mutation in the non-mutated version of the chromosome. So now there are two mutations in the cell. This in turn is thought to allow growth of a cyst within the kidney. However, this is still somewhat controversial, and in our own group, we have looked for second mutations in the PKD genes, and we have found that some cysts will have many, many different mutations in different genes, but not the PKD genes. So it does seem that cells that contain at least one PKD mutation may be susceptible to accumulation of further mutations. Next slide, please. So in ADPKD, there is significant variability. If you focus on the left panel, the red dots resemble or represent PKD1 and the blue dots towards the bottom, PKD2. So it's pretty clear, along the bottom you have age, and on the other axis it's showing total kidney volume. So you can have a wide variety of total kidney volume, even if you have PKD1. Typically, the kidneys will be larger than those with somebody who has PKD2, but you can see there's a lot of variability in kidney size, kidney volume. Next slide, please. So why is this variability present? Well, there are a number of factors. The mutation, the gene mutated PKD1 versus PKD2, the mutation type, the mutation location, modifier genes, all of these may have some effect on disease severity. In addition to this, there are other non-genetic factors that can also have an influence on disease. And these can include sex, male versus female, blood pressure, obesity, to name just a few. Next slide, please. So other factors that we know that will affect PKD severity are male gender, associated with slightly larger kidneys, slightly earlier progression to the need for kidney replacement therapy, hypertension. So hypertension is very common among individuals who are affected by PKD. And if hypertension is not well controlled, this can cause more rapid growth of the kidneys. Further kidney injury in the form of kidney stones, we have recent data showing that that may also affect severity and rate of progression of disease, or repeated infections. Being overweight or obese has also been shown by our group to be associated with larger kidney volume and somewhat faster progression or growth of the kidneys. And it's pretty obvious that if an individual carries a second disorder that is also going to have an effect on the kidneys, such as type 2 diabetes, that's also associated with more larger kidneys and earlier onset of high blood pressure. Next slide, please. So disease severity is variable even among members of the same family. And that can be a mix of environmental, or everyone within the same family, it's important to realize, will carry the same primary gene mutation, but modifier genes can also affect that, and there can also be environmental effects. However, when you see very great variability in disease, there's usually other reasons for this. Next slide, please. So some of these causes of earlier development or loss of kidney function can be due to PKD1 being more severe compared to PKD2. Truncating mutations typically are a more severe effect, and somewhat earlier other things that affect can be gender, male versus female. Next slide, please. Two classification systems have been developed to predict more rapid progression. One was developed by the Mayo Center, and they divide disease into 5 categories named A through E. Those with category C, D, or E. The classification is based on height-corrected total kidney volume, so having larger kidneys at a younger age is associated with more rapid progression. This next slide, please. A second scoring system, the PKD score system, was developed. This takes into account a wider variety of things, such as the gene mutated, the type of mutation, age at early onset of hypertension, early urology-related problems, and it gives a number, so a higher score in the PKD score is associated with higher risk for more rapid progression. Next slide, please. So no family history is not unusual. It may be just that the family history is not known. It can be due to a brand new mutation. That's probably occurs in about 20%. And it could also be due to a mutation, a mild mutation inherited from both parents. So let's look at that. Next, please. This is also called a hypomorphic allele, which I described earlier. Next slide, please. So here we have a family, and in the grandparents' generation, they had a missense mutation, both grandparents. It's the replacement of the R, which is an arginine by a cysteine residue. So disease was pretty mild in the grandfather. You can see he had many cysts in his 70s, but still maintained kidney function. However, 2 of those children, indicated by the fill blue boxes, both inherited from both parents the copy of the alternate form of the gene, the CC form, and they did go on to develop kidney loss of kidney function, but it occurred later in life, so it's a mild effect. And you can see from the last generation that it's very similar to ADPKD2 in the sense that it's associated with mild disease. Next slide, please. So what is mosaicism? Next slide, please. This occurs when one cell develops a mutation after the egg has been fertilized. So it's when the cells are dividing, and any cell that derives from that one that has the mutation will also have a mutation, whereas the majority of cells are without mutation. So you end up with an individual with differential expression of that mutation in different tissues. Next slide, please. So here we have an example. Here a 17-year-old was diagnosed with multiple cysts, so kind of fairly severe disease. Initial screening of the father and mother failed to identify a mutation. This child, the daughter, actually had been identified with a truncating mutation. So the father, however, did have multiple cysts. This further analysis of the parent showed that in the father's cells, in the blood cells, the mutation was only present in about 3%. And in buccal cells that line your mouth, these are the 2 types of cells often used for genetic testing. So it would have been easy to miss this mutation. However, in the sperm, it was present in a higher proportion, and that in fact is what happened. This child resulted from fertilization of the egg with one of the father's sperm carrying the mutation. This child is not a mosaic. They've inherited what we call a germline mutation, so they will have fairly classic PKD. Next slide, please. So another cause of potential lack of family history is if, in fact, it is not ADPKD, but it is a mild form of ARPKD. Both parents, again, are not going to be expressing symptoms, but this is the type that could express or be diagnosed in adulthood in a child without apparent affected family history. Next slide, please. So here we show the different types of mutations, and I'll just point out here, if you have a mild mutation, you lose a small amount of probably the protein function, but when that's accompanied by a traditional mutation, you might lose a very large percent of function. Next slide, please. And that is shown by this family. The family had a truncating PKD1 mutation, which was passed down here to a son, but the son married somebody with a hypomorphic allele, and this hypomorphic mutation and the PKD1 truncating mutation were passed to the child, and the result was very early diagnosis in utero. Next slide, please. So let me just very briefly talk about personalized medicine. This is development of a way to directly correct a mutation occurring in a certain region of a gene. It might be a region that's necessary for transport of the protein to its correct functional location in the cell. This approach has been used pretty successfully in cystic fibrosis, where there are potentiators that will increase the activity of the remaining protein, or they can be correctors that will assist with transport of the mutated protein to its correct site in the cell. Next slide, please. Here are some reasons why it is possible to consider genetic testing. I'm going to go through these fairly quickly. If there is an inconclusive diagnosis it could be based on atypical cyst formation. It might be a reason, or very severe early onset disease is also a reason to consider genetic diagnosis. Obviously, workup to be a kidney donor is another reason. Let's go to the next slide. However, there are also reasons that people give for not wishing to have genetic diagnosis. One is financial concerns regarding life insurance, uncertainty about disease. Some people don't know about the heritability risk of PKD. Some people are just concerned about depression. They just don't want to know about whether they're affected. And further, there's a concern about medicalizing family planning. And for a child, if there's no specific treatment available, you can debate what the value is of early diagnosis. Next slide, please. I'd just like to bring to your attention the ADPKD registry. If you have not signed up for the registry already, please consider it, because when we gain very large numbers of people, this will be very effective in making or learning more about the progression and the different complications that are associated with ADPKD. And with that, I'll leave you and take questions.
Great. Well, thank you so much, Dr. Gittimer. As a reminder, please keep your microphones muted and type any questions you have into the question box. We have received one question already. How do genes from non-PKD parents impact disease progression?
Okay. Well, it is possible that from a non-affected parent, you could inherit a modifier gene. When that gene is present in a non-affected parent, it may not have very significant effects. But the combination of this defect and another gene on the background of PKD could result in more severe, or it could be a protective effect. To think about this is, if you think about a gene that might cause earlier onset of high blood pressure coming in from the non-affected parent, when that's on the background of PKD, it could result in even earlier development or more severe high blood pressure in an affected patient.
Okay, great. Another question related here. I've always wondered how other genes from my non-PKD parent father impacted my disease. Many of my cousins also have PKD, but it has been variable in their progression. Is that due to the non-PKD parent?
It can be, or it cannot be. Environmental factors can have a significant effect on your PKD. So we talked first of all about sex being male. Males tend to have a slightly more rapid progression of disease than females. There are also other effects, such as making sure that you have good blood pressure control. So someone, for instance, who has high blood pressure but does not try and take care of the high blood pressure, or is not, that can also have an effect and cause faster progression of disease. So it doesn't have to be just a modifier gene. It can be environmental effects. We've talked a little bit about obesity, overweight. So being healthy, one family member can adopt a healthier lifestyle compared to another. So all of these things can have some effect on disease severity.
Thank you. Another question here. Do you know why some people suffer more from PLD than others? Is there a specific mutation they are looking for to see what is causing this?
To date, it is not known that specific PKD mutations are associated with more severe PLD than others. However, as you saw, there's a list of other genes that are potentially associated with ADPKD. Interestingly, many of these genes are also associated with polycystic liver disease. So it is possible that someone who co-inherited, let's say, a mild mutation, even in one of these other genes, so it's a kind of a modifier, if you like, on the combination of the PKD background, may be more susceptible to polycystic liver disease.
Okay, can you comment about the effect of epigenetics?
So epigenetics in ADPKD is a relatively new area that's been examined. So we do know that in many diseases, epigenetics can have a profound effect on disease progression. I think that it's a fairly new area of research in ADPKD. We know, for instance, that microRNAs can have a significant effect on progression of PKD. This is from Vishal Patel's work at UT Southwestern. DNA methylation can cause changes in expression of genes that can also have a profound effect. So I think at the moment, we're really just scratching the surface regarding epigenetic studies in ADPKD. But I think that it's very likely, based on existing data, that we're going to find that there are some very substantial effects, and we will learn about them in the future.
All right. If the child is born from IVF and PGP, when this child is getting to adulthood, is the next generation still at risk of PKD?
No. If the child, by definition, would not carry PKD if the parents have gone through pre-implantation genetic diagnosis. So that child will be free of disease. So short of a new mutation developing, and obviously that can happen in any individual, but it would be very unlikely. That child would not have affected children, so the grandchildren should be free of disease. That is correct.
Well, unless if there are no more questions, we'll just wait one more minute. Here we go. If a PKD patient has one or more natural children, does that environmental factor increase PKD progression?
I'm not sure that I exactly understand the question. If the question is whether you've already, let's say, had a child with PKD, what is the likelihood of you having a second child with PKD? So in the case of the dominant form of polycystic PKD, there's a 50-50 chance for every child that is born to inherit the mutation from the affected parent. So you can end up with a family with 6 children, all of whom could be affected, because it's a 50-50 chance for each child that is born. Likewise, you could have 6 children and none of them could be affected. So having one affected child, and I apologize if this is not the intent of the person who had the question, does not mean that there's any more likely effect that you'll have a second child with PKD or an unaffected child. It's independent for each child.
Okay, thank you. The next question here, is there a genetic relationship between Wilma's tumor and PJD?
I guess they mean PKD here. Yeah, probably.
Yeah, PKD.
I don't know. This is kind of an interesting question. There's literature suggesting that I've seen both suggestions that PKD is related with a higher risk for development of different kidney tumors. And also, I think there's probably more literature suggesting that that is not the case. There doesn't seem to be, in general, I think, a higher incidence of any kind of a renal cancer associated with individuals who have PKD. Now, this is a little bit different post-transplant because the immunosuppressive medications that are used post-kidney transplant can also alter susceptibility to certain types of cancer.
Okay, thank you. And then for our last question, does being pregnant accelerate PKD disease progression?
Some early studies from our group had showed that women who've had multiple children did have somewhat more severe disease. So there's thought to be an effect of possibly of estrogen. Some parents of multiple children. However, it's not a very significant effect. I guess that kind of answers the question. Pregnancy on its own right, a single pregnancy, should not affect progression of PKD now.
Well, that is all the time we have for questions. Dr. Gittimer, any additional comments before we wrap up this session?
Well, I'd like to thank the audience, and I'd like to thank you, Ashley, and the PKD Foundation again very much for allowing me to present this talk. And most people know my contact, and I'm always available and more than happy to ever answer anybody's email. So
Well, thank you, Dr. Gittimer. Thank you all for attending this session.